Hi everyone, welcome to my lecture on the gastrointestinal system. I am Dr.Navneeth Selvan. So today we'll be seeing about peptic ulcer. So this video will be in two parts. So first we'll see about the introduction, and then we'll see about the anatomy, the histology, the physiology, the pathophysiology, and at the last we will see about the pharmacology of peptic ulcer. So let's start with the introduction into peptic ulcer. So before going to that, we'll see about the stomach. So we'll see about the anatomy of the stomach, and then we'll dwell into the pathophysiology. So everyone knows how the stomach is like. So this is the stomach, as we all know. So now we will see some of the parts of the stomach. So this is the lower esophageal sphincter, and this is the pyloric sphincter. This is the greater curvature of the stomach. This is the lower curvature. This is the pyloric part or the pylorus. This is the fundus, and this is the body of the stomach. So these are the few anatomical parts of the stomach we should know before dwelling deep into the peptic ulcer as a topic. So the stomach consists of various mucosal folds, which are called the rugae. So what is their purpose exactly? So when we eat food, what happens? That the stomach expand to increase the surface area. So these rugae expand to increase the surface area of the stomach. Hence we are able to eat the food which we want. So example, someday we eat little food, someday we eat more food. So these expand to give the surface area to the stomach. So after knowing these parts, we should know the function of the sphincters. So what happens when acid or any HCl is secreted in the stomach? So this sphincter prevents the reflux of the acid into the esophagus, and this sphincter does not allow it to enter into the duodenum. So these are the main functions of these two sphincters. So next, what we should know is about the gastric pits which are present in the stomach. So these gastric pits, what they consist of is the glands. So these pits consist of glands. So what do glands consist of? These glands consist of important cells which are present in the stomach. So we should know about the cells which are present in these glands, and each cell has a particular function. Only if we know the function of these cells, we can know which cell will secrete what and what all functions does it serve. So the first important cell in the gland which is present is called the mucin cells. Next cell is your chief cells. Next is parietal cell. Each cell has a separate function. We will see about these three cells, then we will see about the next three cells in detail. So these mucin cells, they secrete mucus. So what is the function of the mucus? The mucus serves as a protective function. If this is the stomach, and if hydrochloric acid is being secreted all the time, what will happen to the stomach layer? So it may get dissolved. So this mucus, it forms a whole protective lining around the stomach so that the stomach does not get dissolved. So that is the function of the mucin cells. The chief cells secrete something known as pepsinogen, which help in the main digestive function of the stomach. The parietal cells secrete the most important HCl, and they also secrete the intrinsic factor. So each cell has a separate function, and you should know the function of each cell so that you can go ahead with the treatment of the peptic ulcer. So next, the three main cells are called G cells, D cells and ECL cells. So the G cells are referred to as gastrin cells. D cells are also called somatostatin cells, and ECL cells are called enterochromaffin like cells. So what do G cells secrete? G cells secrete something called as gastrin. D cells, they secrete somatostatin, and ECL cells or enterochromaffin like cells, they secrete histamine. So let me draw a gland for you so that you understand how and where these cells are present. If you take or zoom into a gastric pit in the stomach, it consists of the gland like this. So imagine this is a gastric pit, and this consists of the gland. So at the outset you will have your mucin cells or the surface mucosal cells, and then while you dig deep into the gland, you will have the other cells which are present here, the chief cell, the parietal cell, okay. And as you go into the pyloric part of the stomach, you will find the G cell, D cell and enterochromaffin cell. So what this mucus cell will do is that it will secrete mucus, as I told, and this will line the stomach layer with mucus, protecting it against the hydrochloric acid. This chief cell secretes pepsinogen, which reaches the surface where it gets converted to pepsin. So this is the function of the chief cell. The parietal cell, the function is secretion of this HCl, and then you have your gastric cells, that is which secrete your gastrin, and then you have your D cells, and then you have your enterochromaffin like cells which secrete histamine. So now we must be clear with what is happening with the anatomy of the stomach, and what is the histology, and what is the function of all the cells. So with this knowledge, we will go into what is peptic ulcer. So peptic ulcer is a broad term. It consists of both gastric ulcers and it consists of duodenal ulcer. So what happens when your stomach layer gets burrowed or gets eroded because of HCl? It leads to something called as ulcer. So this is how an ulcer is formed. So the HCl erodes the layers of your stomach. So this may occur in any part of the stomach, and based on that we divide it into a gastric ulcer or duodenal ulcer, right? So how does the patient present? When the patient comes, he will have a dull gnawing pain, and he will express his pain as chronic or acute depending upon the type of ulcer he has. So then what needs to be done is you need to treat the patient. So before that, we should know about the treatment so that we can give the appropriate treatment to the appropriate patient based upon the type of ulcer he has, gastric ulcer or duodenal ulcer. So why does this ulcer first of all arise? Why does the HCl burrow into the layers of stomach when everyone secretes HCl? Why only a few of us suffer from this disorder, and while the most of us do not suffer from this disorder? So when you take the HCl, for example, it does not affect normal individuals. So there are various protective factors which protect an individual from HCl. So what are the various protective factors, and how does your ulcer arise? So the major protective factor, like I told, is the mucus layers. This mucus layer prevents the HCl from burrowing into the layers of the stomach. Second is prostaglandins. prostaglandins play a major role in the protective factor against ulcer. So what happens when these factors are compromised? This leads to ulcer. So what could lead to this? So the lifestyle changes, foods, oily foods, and most important in the Indian scenario, alcohol. So all these may lead to compromising of these protective factors, and hence peptic ulcer as a result. And in this generation, when we see IT professionals or students, they don't tend to have breakfast or they don't tend to eat proper food. So what happens? The amount of HCl secreted is so large that it tends to compromise the protective factors. So majorly when we take peptic ulcer, it is an imbalance between the protective factors and the destructive factors. So how we overcome this is what we are going to see. But before that, how is HCl secreted? Only if we know the secretion of HCl, we will be able to learn about the treatment and how the various disorders cause the peptic ulcer. So without knowing how HCl is secreted, we will not be able to study about the treatment of peptic ulcer. So let's see about the secretion of HCl from the parietal cells, how HCl is secreted. Let's now see the secretion of HCl. So it's very vital to know about the secretion of HCl before we proceed to the treatment of the peptic ulcer. So before we go into the secretion of HCl, let us zoom into a gastric pit. So the gastric pit, like I said, consists of various cells, but to understand the secretion of HCl, we need to know about the function of two important cells. So let me zoom into the two important cells. One is the smaller cell and one is the bigger cell. The smaller cell is the ECL cell and the bigger cell is the parietal cell, right? So the ECL cell consists of certain receptors and the parietal cell consists of certain receptors. So the most important receptor is your CCK2 and here is your muscarinic receptor, that is M1, and here also it consists of the CCK2, H2 receptors and your M3 receptors. The knowledge of these receptors is very important to understand the secretion of HCl. So let me now tell you what acts on these receptors. On the CCK2 receptors, your gastrin acts. This gastrin is secreted from the G cells which are present here, and the somatostatin inhibits this secretion. Here there is action of your acetylcholine. So this results in secretion of histamine from the enterochromaffin like cells. So where does this acetylcholine come from? So now we have to understand the secretion of HCl in accordance with the acetylcholine. So this acetylcholine comes from your dorsal motor nucleus stimulation. So when we think about food, the sight, smell, taste or even the anticipation of food, the dorsal motor nucleus is stimulated. What I said, the sight, smell, taste or even anticipation of food, all these cause the stimulation of the dorsal motor nucleus, from which it sends signals via the vagus nerve to the enteric nervous system to which your stomach is coupled, right? So when there is stimulation of your dorsal motor nucleus, so ultimately via the vagus nerve you will get secretion of acetylcholine. This acetylcholine will in turn act on the M1 receptors and M3 receptors, ultimately resulting in secretion of HCl. Now we will see these next steps by which your HCl is secreted. So when there is secretion of histamine due to the stimulation of your M1 receptor, what happens? The histamine goes and binds to its receptor which is present on the parietal cell, which is the H2 receptor. We need to know the classification of each receptor to understand their functions. I'm going to rub this now. This H2 receptor is a GS type of receptor. M3 receptor is a GQ type of receptor, right? The M1, M3, M5, they all are GQ type of receptor. So what is GS here and how does it act? Here the ATP is ultimately converted to cyclic AMP because of the action of adenyl cyclase, right? Here also, because of the PLC activity and IP3 activity, you get calcium intrusion. Here also the same calcium intrusion takes place. So all this together lead to activation of protein kinase. In the last lecture we were talking about the carbonic anhydrase system. So there is a carbonic anhydrase system in the parietal cell as well. So here the carbonic anhydrase system comes into play. Right? So there is formation of carbonic acid which gets dissociated into H plus and bicarbonate ions. Okay, this bicarbonate gets out of the parietal cell and there is intrusion of your calcium by this antipode system. So this is a antipode system. So in every antipode system there's an ion going out and there's an ion coming in. Because of the coupling with the carbonic anhydrase system, there is efflux of your bicarbonate and influx of your chlorine. So there are other two channels here which are the most important channels in peptic ulcer. So please concentrate on this part. There are two channels here. So one is a antipode system and one is a unipode system. So this antipode system, what it does is that it takes this H plus ions and it leads to efflux of the H plus ions for influx of potassium, right? So this H plus ion goes out of the cell and potassium ion comes inside the cell. This potassium again, here it goes out along with your chlorine. So this chlorine gets fluxed here. So this together leads to secretion of HCl, right? So there is coupling of these both channels too. So ultimately what happens, there is secretion of HCl. So there's an interplay of all these channels and receptors for the secretion of HCl. So let me go through the whole system again so that you get a grasp of how HCl is secreted. First of all, when there is sight, smell, taste or anticipation of food, there is stimulation of the dorsal motor nucleus. When there is stimulation of the dorsal motor nucleus, what happens? All the signals via the vagus nerve, they enter into the enteric nervous system. From the enteric nervous system, the acetylcholine is secreted which acts on the muscarinic receptors, that is M1 in ECL cells, M3 in your parietal cells. Everywhere the acetylcholine goes and acts, which leads to intrusion of your calcium. This we should know what kind of receptors all these are to know in detail what each receptor does. So the H2 receptors are a GS type of receptor. M3 receptors are a GQ type of receptors. When GS receptors are activated, what happens? There is secretion of cyclic AMP. So at the end, there is activation of protein kinase because of the activation of all these receptors. This protein kinase is vital to the functioning of this channel as such. So this channel is what we call is the proton pump, right? So what happens in peptic ulcer is what we are going to see next. So please keep this in mind and we will go into what happens in peptic ulcer. So peptic ulcer, there is huge secretion of HCl, and this HCl goes and destroys the layers of the stomach, as I said before. So what can I do to prevent that? What is the line of treatment which I can do? So let's concentrate on each receptors and come out with the treatment. So what I can do is that we'll go from the easy to the difficult part. So what I can do is I can block this receptor here, which is called H2. So we came up with a line of drugs called the H2 blockers, right? So these H2 blockers, they are called cimetidine, ranitidine, famotidine, so these are some of the drugs which are under this classification of H2 blockers. So what these drugs do is that they go and block this receptor. So what happens when you block this receptor? When you block this receptor, there will be inactivation or no activation of your protein kinase, but these two channels will still be active because there is still secretion of your acetylcholine, which is acting on your M1 receptor and M3 receptor. So yes, you will have effect, but not that much of an effect to stop or cease the secretion of HCl. So these are the first line drugs which are used, which is called the H2 blockers. And cimetidine was the prototype, or is still the prototype in all the Indian textbooks, and it has major adverse effects called rebound acidity, because when it blocks the H2 receptor, what happens? CO2 is secreted and it leads to something called as rebound acidity, and hence it was taken off the market, and now the most used drug in the Indian scenario is ranitidine. So these are the first group of drugs used in the treatment of peptic ulcer. So they will reduce the gastric acid which is secreted. So next, coming to another important group of drugs which were used earlier, and now the use has decreased to a significant extent because of the adverse effects. These are called muscarinic receptor blockers. Mainly two drugs used nowadays, but not in the US or India as such, is called pirenzepine and telenzepine. So the idea behind inventing these drugs was that if we block the muscarinic receptors, the acid secretion will decrease. But what happens is that muscarinic receptors are not only present in the stomach, but they are present in a wide organs. So what happens when you block a muscarinic receptor? Not only in the stomach, but everywhere the muscarinic receptors will get blocked. So ultimately what will we get? Not the benefit of the patient, but at the end we will get lot of adverse effect. Hence this is not that much useful, and H2 blockers are still the mainstay of treatment. And what will have absolute effect? So can you think of some place where you can block and the whole HCl secretion will be blocked? Okay, so let me think of one. So can we block the proton pump here, the ultimate channel which will lead to secretion of HCl? What if we block this channel here? What will happen? Yes, the HCl will not be secreted. So these are the newest group of drugs and which are very, very effective in the treatment of peptic ulcer, which are called PPIs, proton pump inhibitors. Okay, certain drugs in this group are omeprazole, pantoprazole, esomeprazole and lansoprazole. So what these drugs do is that they block the proton pump and ultimately inhibit the formation of HCl. So how they block the proton pump? So these drugs, they go and form a complex with a sulfonamide. This drug sulfonamide complex, so these are present as prodrugs. So this prodrug sulfonamide complex goes and binds to the sulfhydryl groups which are present in the proton pump. So what happens when they bind covalently to this sulfhydryl group which is present in the proton pump? It causes inactivation of this proton pump. When there is inactivation, there will be no extrusion of H+, and when there is no extrusion of H+, there will be no secretion of HCl. That is the entire mechanism of action of the proton pump inhibitors. So this is just one side of the story. Now let's see the other side of the story. So now coming to another new cell which is called the surface epithelial cell. This surface epithelial cell consists of two important receptors, which is the EP3 receptors and unknown muscarinic receptor. So when I started the lecture, I talked about the protective factors. One of the most important protective factors which I was talking about is the prostaglandins. So prostaglandins, they form a very, very important role in the protection of the stomach. Prostaglandins. So these prostaglandins, mainly E2 and I2, what is their function? Their main function is to help in the secretion of mucus and also prevent the action of cyclic AMP. So these are the two important functions of the prostaglandin. One is secretion of mucus and also increased secretion of bicarbonate from this action on EP3. So the prostaglandins, they act on the EP3 and help in secretion of mucus. They help to stop the secretion of cyclic AMP and also increase the secretion of bicarbonate. So prostaglandins have all these functions. So years before, what was seen that persons using NSAIDs, it lead to increased peptic ulcer in individuals. So what is the connection between NSAIDs and peptic ulcer? So let's see now. So when they discovered NSAIDs, so what was the most important thing it did? It did was blocking the cyclooxygenase. So what happens when you block the cyclooxygenase? Ultimately prostaglandins will not be secreted. So when there is no secretion of prostaglandins, what will be the individual more prone to? He will be prone to peptic ulcer because there is loss of all the protective functions this prostaglandin provides. So ultimately individuals on NSAIDs tend to develop ulcers because of loss of prostaglandins. So we came up with a new class of drugs called prostaglandin analogs. So the main group of drug which was introduced was misoprostol. Okay, 200 micrograms. So this misoprostol was a prostaglandin analog which did the function of the innate prostaglandins in the body. So it provided all the functions of the prostaglandin needed, but still it didn't provide total recovery, right? So hence the individuals which were on NSAIDs, they switched over to new drugs called COX-2 selective inhibitors like celecoxib and other coxib drugs, but still they reported that they were having increased incidence of peptic ulcer. Hence, no drug can provide complete function of prostaglandins innately in the body, including misoprostol. So this is the second story of prostaglandins. So we have three group of drugs now. One is H2 blockers, next is the proton pump inhibitors, and the prostaglandin analog, which is the misoprostol. Newer drugs like N-prostil are there in the market, which also have the same function as this. Prostaglandins analogs are also useful in something called as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is somewhere you have increased secretion of HCl, right? So apart from all this, what can we try to provide relief from the symptoms of HCl? So what we can do, or which is present as a OTC, is your gastric acid neutralizers. So what are gastric acid neutralizers? So something called as Digene, which is there in the market for a long period of time. By this, what we are trying to do is just we are trying to buffer the HCl which is secreted by the parietal cell. By buffering this, we are trying to reduce the symptoms, but this gastric acid neutralizers are not a complete cure for peptic ulcer as such. So what are the gastric acid neutralizers which we know of? So first we came up with something called as aluminium hydroxide. Aluminium hydroxide, right? When aluminium hydroxide came into the market, yes, it was quite successful. Yes, it neutralized the gastric acid, the patient were not having any symptoms, but an important adverse effect which was noted was constipation. Then they came up with another drug called magnesium hydroxide. This also was quite good, but again it had an important adverse effect called diarrhea. So what the R&D people did was they combined both of these and came up with a new combination of aluminium hydroxide and magnesium hydroxide, which is there in the market today, which goes by the trade name as Digene, right? So this is an important gastric neutralizer where you get a combination of aluminium hydroxide and magnesium hydroxide. Apart from this, you have many other drugs which are there for the treatment of peptic ulcer. Till now we saw about the drugs which are used in the treatment of peptic ulcer, which led to neutralizing of the HCl and which led to decrease in HCl formation. Now we are going to see about an organism which leads to formation of peptic ulcer, right? This organism is very vital, which is known as the Helicobacter pylori. Helicobacter pylori is normally present in all the individuals, but only a few develop peptic ulcer as such. So what is the science or what is the pathology behind the Helicobacter pylori, and why does this organism as such cause peptic ulcer? That's what we are going to see now. So Helicobacter pylori, it normally stays in the stomach, right? In circumstances when there is hindrance of the protective factors, like I said, something to do with the decrease of mucus like alcohol consumption or decrease in the prostaglandin formation, what this Helicobacter pylori will do is that it produces ammonia. This ammonia will neutralize the HCl and lead to the action of Helicobacter pylori on the layers of the stomach. So when the Helicobacter pylori starts acting on the layers of stomach, what will happen? So any bacteria which you take, it will have its own toxins. Helicobacter pylori has its own toxins. So the knowledge of the toxins of Helicobacter pylori is vital in understanding what is going to happen with the Helicobacter pylori and how it will lead to the formation of peptic ulcer. So let's now see which are all the toxins which are secreted by the Helicobacter pylori. Two important toxins which are called CAG-A and VAC A. CAG-A is called cytotoxin associated gene A. Cytotoxin associated gene A. So this is the most important toxin and the most studied toxin of the Helicobacter pylori. Next is the vacuolizing cytotoxin A, which is called the VAC-A, vacuolizing cytotoxin A. So what does this cytotoxin associated gene A do? Let me zoom in into a muscle layer of the stomach. So these cells in the stomach consist of tight junctions, right? These tight junctions, they are secured by a mucous layer, and then you have your HCl here. So in circumstances like in alcohol consumption or where your prostaglandin is not acting, the mucous layer is deprived. So what happens? This HCl comes and acts here. But then again, the additional layer or the additional factor which prevents the HCl from acting on further layers of the stomach is your tight junction. So what this CAG-A does is that it disrupts the tight junctions here. So when there is disruption of this tight junctions, HCl will peak or seek into the cells, right? This part is almost resistant to HCl, but this surface is not resistant to HCl. So the HCl will start acting like this. So what happens when it start acting? It will create a burrow here. So the entire cell will get digested. So more HCl will seek in. So what happens? It keeps on going into other layers of the stomach, right? So the disruption of this tight junctions here is the most important and critical factor by which the CAG-A toxin of the Helicobacter pylori can cause peptic ulcer. This vacuolizing cytotoxin A will create vacuoles and lead to self-destructions of the cells of the stomach. So they will lead to apoptosis of the cells of this stomach. So this is what VAC-A will do. So importantly, these two toxins, when they act together, will destroy the layers of the stomach and they will make the HCl to act on the cells and ultimately cause various stages of peptic ulcer. So this is how the Helicobacter pylori causes peptic ulcer. So this can't be treated with our traditional drugs, which are your PPIs or your H2 blockers or even the prostaglandin analogs, because the HCl has dwelled deep and importantly you need to kill the organism on a whole. So what are the drugs which we can use here are clarithromycin. You can use amoxicillin. You can use metronidazole. And we can use tetracycline. So can we use these drugs randomly? No, we can't. Hence we came up with regimens in which these drugs are given so that we can treat Helicobacter pylori in a much good manner. So what are the regimens? So first regimen which we came up with was called the triple drug regimen. Triple drug regimen, or even you can write it as triple regimen in your exams. So in the triple regimen, it consists of treatment with 1 PPI plus clarithromycin 500 mg plus you can give a metronidazole again 500 mg, or you can substitute the metronidazole with amoxicillin 1 gram, right? So this is a triple drug regimen wherein you give 1 proton pump inhibitor, which may be omeprazole or rabeprazole, and then you can give a clarithromycin and a metronidazole or amoxicillin. This is called a standard triple regimen. And then when this does not work and when your ulcer has reached to a second stage or even a triple stage, what you can do is you can go to a quadruple regimen. Wherein you give 4 drugs, right? Same, you can give a PPI, then you give metronidazole, and then you give a bismuth subsalicylate, and then you give a tetracycline. This PPI can also be substituted with a H2 blocker. So you have 2 regimens now, which is the triple regimen and the quadruple regimen. Okay, the triple regimen consists of 3 drugs, which is a proton pump inhibitor, clarithromycin, metronidazole or an amoxicillin. And then you have a quadruple regimen wherein you can give a proton pump inhibitor and you can give metronidazole followed by bismuth subsalicylate and tetracycline. You can also substitute the PPIs for a H2 blocker. So these are the 2 regimens which are very much useful in controlling the infection by the Helicobacter pylori, which has been found to be very useful. Now let us summarize the whole treatment of peptic ulcer. So one is we neutralize the gastric acid. So how do we neutralize the gastric acid? With aluminium hydroxide, magnesium hydroxide and various other drugs like your simethicone and other drugs. Next, we decrease the gastric acid secretion. For that we have H2 blockers, the tidin group. So you can remember with tidin, ranitidine, cimetidine. So they all fall under the H2 blockers group. And then we have your PPIs, which are called prazoles. Remember this word. So omeprazole, lansoprazole. So they all are called prazoles. And an important clinical point to know is that they are metabolized by something called as CYP2C19. So hence you need to use this with precaution, and mainly this is present in Asians rather than Americans. So please use this drug with caution. Next is your prostaglandin analogs. Which is mainly your misoprostol and some drugs like N-prostal. Next is your muscarinic receptor blockers. Okay, which is your pirenzepine, telinzepine and other drugs. So apart from these drugs, you have something called as the drugs which are used in the treatment of Helicobacter pylori. And the entire regimen, like I said, you have 2 regimens, the triple regimen and quadruple regimen. With all these methods, you can control peptic ulcer to an extent wherein the patient does not experience any symptoms. Thank you for listening to my lecture. Please subscribe to my channel and stay tuned for more videos.